score assessments of the health information systems revealed that many countries' weakest part of the health information system was CRVS. And as many of you know, there is another score assessment ongoing, which we hope, led by my colleague Anne, who's in WHO, will be released later this year. And we're expecting, again, a lot of focus on CRVS, which provides an opportunity for all of us to look at CRVS in more detail and for partners and governments to look at investment in CRVS systems. Of course, CRVS is not just health alone. In fact, the health component of CRVS is a relatively small part of CRVS, which is why the Health Data Collaborative, which is a collaborative of partners, governments, donors, academics, come together and look at challenges and look at solutions together. So in the CRVS working group, we're lucky enough to have one of our co-chairs of the CRVS working group, my colleague Doris, who's on the call today. Other co-chairs may join later on from Vital Strategies, from UNICEF, from a UNFPA. So thanks to everyone for joining today. Thanks especially to the presenters and to Pandula for coordinating. We're going to hear from a range of different experiences on CRVS, given the Sri Lankan experiences. If everyone can basically listen for around half an hour, digest and take note of any questions that you might have, and we'll have a discussion at the end where you can ask questions, or even better, come up with some solutions and share your experiences on CRVS and complement the Sri Lankan team as well. So thanks again for joining, everyone. And with that, I'd like to hand over to Romain from Vital Strategies, who's going to kick off the presentation. Thank you, Romain.
Thank you very much, Craig, and hi, good afternoon, good morning, everyone. So today I will present briefly on the regional overview of the Data for Health initiative in Asia and the Pacific. Most of you in this call, I know, knows quite a bit of D4H, so it will be a bit repetitive, so I will try to go over, but I will focus also on what makes the Data for Health initiative work pretty interesting, and particularly on the partnership. So as Craig mentioned, the purpose of the Data for Health initiative is really to ensure that countries have reliable health data to collect reliable public health information to be able to improve the population health and their service deliveries. There are 4 components of the Data for Health initiative. We are mainly talking about the CRVS one, but there is also a data impact program, which is to help policy to make better use of the data and to make decisions. And in a subset of countries, there is mobile phone surveys for NCDs and cancer registry work. Next slide, please. The challenges, as you know, is that worldwide, more than half of the deaths are not registered, and those who are registered do not have a good quality cause of death data. NCDs are increasingly important, and they cause premature death. And the data, if available, are often underutilized for decision making. They are left on the shelf, or they are not utilized as they should be. Next slide, please. So the initiative started in 2015. It's mainly funded by Bloomberg Philanthropies. There is now some additional funding from the Gates Foundation. This is partnering with over 27 low and middle income countries and cities worldwide for what we call the focus countries. And the initiative itself is a partnership. Multiple international organizations are part of the initiative and providing technical assistance and other resources to the countries. As I mentioned, 4 components, 2 components in all countries, and the other 2 components in a subset of countries. Next slide, please. The operating principle of the initiative are really country leadership and ownership, and this is why we mentioned partnering with countries, because they are the one really driving and expressing their needs, and the initiative does it best through the partnership to support those needs. It's focusing on capacity development with people, process, and products at its core. With the catalytic funding that is being invested along with the technical assistance, we are planning with scale and sustainability to make sure that activities are institutionalized. And of course, partnership is very important, partnership with the countries, but partnership with other development partners and other organizations involved in CRVS improvement, particularly. Next slide, please. This is a map overview of the extent of the initiative in Asia and the Pacific, and I believe maybe not every country is represented because this is mainly vital strategies footprint, but you can see that there is a wide spread of programs and support across a lot of countries in the region, including the Pacific, and a variety of focus countries, but also what we call the Global Grants Program. I will get back to it briefly a little bit later. Next slide, please. We'll talk more specifically about partnership and collaboration. Next slide, please. And at the country level, as you know, CRVS, it takes really a village to improve CRVS system. And this is where it's very important to coordinate and to partner with a lot of the agencies, very often with a national steering committee in place, or at least a working group looking after the various involvement of those stakeholders, and it really ranges from the Registrar General that often sits under the Ministry of Interior, Ministry of Justice, to Ministry of Health, but also Ministry of Local Government, custodian of the ID system, Medical Legal Death Investigation System, National Statistics Office, Ministry of Interior and Home Affairs, and increasingly ministries in charge of ICT with all the digital transformation work going on, and also ministries of Economic and Finance to be able to kind of scale and sustain the activities that are implemented at initial scale. Next slide, please. And of course, the initiative is a partnership, and they have a lot and a growing number of data for health initiative partners, including our colleagues from WHO, but also in the region, our colleague from UNESCAP. But on top of them, CDC Foundation, the Global Health Advocacy Incubator, SPC, UNHCR, Howard University. So within the initiative, a partnership. And on top of that, we also partner, of course, with other development partners that are not officially part of the initiative, but also have a lot of activities ongoing, and particularly with the most recent the UN Legal Identity Agenda, clarifying the linkages to legal identity, and now beyond with the digital public infrastructure. So a lot of the agencies working on this are also critical collaborators, such as the World Bank, ID4D particularly, but also UNDP, and of course, more traditionally, UNFPA and UNICEF, who's been working in this field for quite a long time. Next slide, please. So the CRVS program really, next slide, please. It's really focusing beyond harvesting health data to also ensuring everybody has a legal identity, now digital identity linked with the life cycle approach that has been clearly explained under the UN Legal Identity Agenda, and really unlocking a lot of the various benefits that people should be entitled to. Next slide, please. So really, CRVS matters both at the individual level because of the legal implication that it has based on birth and death registration, and really trying to reach universality of those birth and death registration, but also for government to have really a handful of information through vital statistics to priority set, to do policy making, to do impact measurement, but also to measure their progress towards the Sustainable Development Goals. 12 of the SDGs require vital statistics to be able to be monitored. And of course, around individual records, handling individual records to improve service delivery and ensure eligibility for healthcare, voting, and pension, and so on and so forth. Next slide, please. So the scope and scale of the problem, and that's worldwide, it's really that we have still a lot of people that are that do not have proof of legal identity, and in sub-Saharan Africa particularly, so this is beyond our region, but only 1 out of 10 deaths are being registered, and only a fraction of those deaths have a reliable cause of death assigned. Next slide, please. And one of the issues is that a lot of those deaths happened in the community where we have very little information about those deaths. So we really need to find ways how we can ascertain those causes of death and go beyond causes that are usually reported that are not really useful for policy making, such as old age or senility or even cardiovascular arrest. Next slide, please. So the way we approach that is by a multitude of intervention that requires also very strong partnership and coordination with capacity building and technical assistance ranging from governance and coordination through CRVS system improvement to improving facility and community causes of death, ensuring ICD mortality coding according to the coding rules, and good capacity, central capacity for that, understand using improving medical legal death investigation system, and ultimately producing and using vital statistics. Next slide, please. Through fully embedded country coordinator, technical assistance, and the limited catalytic funding, we are able to deliver those technical assistance area to the various countries that are part of the initiative. Next slide, please. I will just briefly explain the other programs, because beyond CRVS and once the data is being collected, there is also a handful of other programs that take over. And this is really about the importance of leveraging those data to make decisions. Next slide, please. As you can see, very often the data are left on shelf, so they are stored but not used. Next slide, please. And really the approach of processing data through people, process, and product to really enhance decision is at the core of the data impact technical assistance. Next slide, please. So in terms of people, if you can help me to move, I think there is some small animation here. So yeah, in terms of people, it's really about strengthening the technical capacity through training and mentoring. And then for the processes, it's really about institutional structure and system to really improving those processes. And finally, the product to enhance the availability of report and dashboard for decision to really lead from processing the data to making decision. Next slide, please. The cancer registry program, it's really about strengthening capacity to track leading global cause of death, which are cancers, increasing number of cancer. Next slide, please. And here we are really talking about population-based cancer registries that have some ties and linkages to civil registration and vital statistics, of course, but they really help to provide data on incident and survival rate. So it goes beyond mortality. It also looks into morbidity. And of course, as you may know, a lot of many low and middle income countries do not have functional cancer registry or hospital-based cancer registry to track and monitor that. Next slide, please. So the cancer registry program will really support creation, expansion, and strengthening of those population-based cancer registries, help the Ministry of Health to coordinate these, create SOPs, and really collect, analyze, and disseminate. At the moment, next slide, please, the program is only operational in our region in 3 countries, namely Vietnam, Sri Lanka, and Cambodia, and they are providing technical support through the initiative to those countries. Next slide. We have the, as part of the initiative, the NCD surveillance via mobile phone survey. I'm not going to expand on that, just so that you know that it's one of the components. This is mainly led by other partners. And finally, next slide, please, the global grants program that non-focus countries are eligible to. And I believe this is for up to $150,000 to receive technical assistance for very specific project around CRVS systems improvement for 12 to 18 months. And I understand there will be a new round coming up very soon around the end of Q3 and beginning of Q4 of this year. Next slide. I think that's it for my presentation for today. You can visit our site from the Bloomberg Philanthropies Data for Health Initiative and Vital Statistics as well. Thank you very much.
Great. Thank you very much, Romain, and your perspective from Vital Strategies, giving a very broad overview of CRVS. And now we're going to delve a bit deeper into the Sri Lankan specific experience. We're going to hear from Dr. Lakshmi Somatunga, who's the Additional Secretary of Public Health Services in the Ministry of Health in the Government of Sri Lanka. So over to you, Dr. Somatunga, and thank you very much for joining.
Thank you very much for giving this opportunity. Much appreciated, especially coming from health sector. It's a pleasure to talk about the role of health sector in CRVS, because health sector plays an important and very significant role in CRVS. Straight away, coming to the CRVS system of Sri Lanka. Next slide, please. If you see the strength, we have a very well-established CRVS system with the coverage. Actually, though we have written 99%, more than 99%, for an example, last year 100% birth registration and 99.9% death registration nationwide. So having reached many quantitative indicators, we must now head for quality. And coming to another strength, we had a very good legal framework until 2020, though it was not reviewed. We had a very good framework covering all the aspects of CRVS. And now, as I said, quality is important as well as quantity. So it was not aligned with the coverage, requiring the need for much improvement. So that is why, if you see the next slides, what we have done is in line with quality. And also, I must admit that Sri Lanka's availability of effective data utilization and availability of CRVS statistics is delayed. We have a gap between the current situation and the real statistics. Now, why CRVS matters to the health sector? First, we are exercising evidence-based health planning, especially the public health sector. We plan on evidence. And also accurate cause of death data is essential for public health policy decisions, because if you compare with other countries in the region, and also we are very comparable with the developed countries, our public health sector, we are determined to prevent all preventable cause of deaths, because within this restricted resource setting, what is prudent is to go for prevention. So that is why it is very essential. And also, CRVS is crucial to monitor SDG, which seek to eliminate poverty and improve lives everywhere. Health is well placed in SDG, though it is dedicated to goal 3. It's much related to all other goals. So CRVS statistics also serve as the denominator for a wide range of population-based targets in SDG. That is why it is so much of importance. Whether it is maternal mortality, child mortality, even NCD prevalence, even the highest, the prevalence in hospitalization, if you talk about even road traffic accident. So denominator is coming from CRVS statistics. And also CRVS enables equal access to health and education by providing individual with legal identity. So not only that, even the social protection, especially when you talk about education and health in Sri Lanka, we have state-run health sector and state-run education. It is free to the customer. And it is very important that you provide legal identity. Next slide, please. Coming to the key roles of the health sector, birth registration. Almost all the births take place in healthcare institutions in our country. It's happy to mention. And when it comes to death notification, approximately 50% of death occur in hospitals because of people tend to die at home. So 50% or 45% to 50% deaths occur outside the hospitals. So for home deaths, general practitioners using standard forms. Forms are used by medical officers, I could not say at hospitals. And but general practitioners also can declare this happening in the periphery, outside the institutions. And also our judicial medical officers under the Ministry of Health conduct the postmortems to provide and also quality assurance for cause of death declared by non-medical persons is also very important because we, health sector, only brought quality into their death declaration, not only by the medical personnel, but others also, because about 40% of deaths in Sri Lanka is declared by the village headman. And the format is used for that, but it is not so compatible with the format and declaration by other medical practitioners. Next slide, please. So despite the high birth and death registration, almost 100%, the quality and timeliness of data was an issue for us, quality and timeliness. Next slide. Therefore, the Ministry of Health Sri Lanka had to take leadership in addressing this critical issue. Next slide. Why we had to take the leadership? Actually, health sector is the sector that proved the achievements and achieving goals by health always, because we are the proud owner of many public health indicators in the region. So we have the experience. That is why I think it is very important that health sector takes the lead role, as especially for the reason that all the births happen in our institution, and cause of death is very important to health, not only health, a nation's health. So thereby longevity of our people. So establishment of National Committee on Data for Public Health Policy in 2019 was a milestone in the history of CRVS journey of Sri Lanka, because we never had such one earlier, because governance is important. So we established this because this subject goes beyond the boundaries of one sector. And we convene this on a quarterly basis, and major stakeholders are, except for us, Register General Department, Department of Census Statistics. These two are very, very major stakeholders, and also Ministry of Public Administration and Home Affairs, under whom these village headmans come, and 45% of the deaths do happen under their administrative purview. And also, of course, Ministry of Justice, especially for medical legal death investigations, they are a part and parcel of the system. And it is important that coordinated action is established, and also collective decisions on CRVS activities. We observed that apart from these issues of timeliness of the paper-based system, quality of cause of death data. Next slide, please. I'm happy to mention about this global CRVS assessment. We have done a lot by health sector, which will be discussed by my colleague next. But before that, before concluding, I would like to say about this global CRVS assessment. There was assessment between 2005 and 2012, and Sri Lanka was placed at not good status. It was low. There were 5 rating, very high, high, medium, low, and very low. So we were placed at low then. Now after doing many interventions, very targeted intervention with the support of all our stakeholders and development partners, like Vital Strategies, we were able to come to good status. Next slide, please. We are happy to announce that when this global assessment has been done in 2023, now our country has been placed at moderate, high, moderate, weak, low, the rating, but we are now at moderate. So little more to go if all other sectors support and work at the same pace we health sector work. I think we will be able to take our country to the highest CRVS, which is high performance. Impossible, maybe difficult, the country to that status. With that, I hand over to my colleague, Dr. Maya Kaduwa. Thank you very much.
Great. Thank you very much, Dr. Samatunga. And again, over to you, Dr. Maya Kaduwa, sorry for the pronunciation, who's going to take us through a lot more detail of connecting the dots and just the emphasis on persistence and collaboration and how you made it work. So thank you very much. Over to you.
Thank you, Craig, and thank you for giving this opportunity. Thank you to the HDC as well. I'm Dr. Nindinu Maya Kaduwa, Medical Officer in Health Informatics attached to the Ministry of Health Public Health Sciences Division. And today I am going to present about connecting the dots, how persistence and collaboration help CRVS to evolve in Sri Lanka. Next slide, please. So what are the challenges in connecting dots? As Madam correctly mentioned, Sri Lanka's CRVS system is a long-term practice system, and there have been no change since its inception. So the persistence, we had to address which persistence. And there was a huge gap of CRVS statistics. So to improve these statistics, we have to improve the timeliness also. And there were capacity gaps. So we had to carry out capacity building on the course. And of course, there was lack of multi-sectoral coordination. The intersectoral coordination has to be established. And as common problem to all the developing countries, we have limited resources. So resource management and also collaboration with development partners played a crucial role. Next slide, please. So let me explain the journey so far. Next slide, please. So we initially focused on the deaths, quality of the cause of death data of the CRVS system. As Madam mentioned, around 50% of the deaths occur in community deaths, community at homes, and we remain occurs in the hospitals. So we addressed each and every pathway to improve the quality of data. Next slide, please. So the main milestone in the for the CRVS system in Sri Lanka was conducting the legal review of the CRVS system of Sri Lanka in 2020. It was conducted through comprehensive reviews and formative interviews, and it was coordinated by the Office of the Actual Secretary Public Health Services, Ministry of Health, in collaboration with Vital Strategies and Global Health Advocacy Incubator. And Sri Lanka was one of the first countries in the region to conduct legal review. Next slide, please. Then we continued to work on medical certification of cause of death improvement. Under that, we had to go for sustainable solutions. So we initially addressed the medical college, medical faculty students, medical students. So we developed an undergraduate curriculum on medical certification of cause of death in collaboration with the university academia of the medical faculties, involving departments of forensic pathology, community medicine, and medical education. And it was incorporated into the curriculum of all the medical faculties in the country through the University Grants Commission, which is the governing body of the universities. Next slide, please. In addition, the in-service improvements were carried out. So we initially started MCCD pilot project. It's a TOT program, training of trainers program on medical certification of cause of death based on the guidelines provided by the WHO. So initially, 125 master trainers from 25 large hospitals were trained as master trainers, focusing on institutions with higher mortality rates. These master trainers in turn conducted training sessions at their respective hospitals to extend the knowledge gain. And of course, we conducted pre and post intervention assessments. Next slide, please. The results showcased a significant improvement in errors in cause of the data after the training. Next slide, please. And also during this for these trainings, we have developed a specific guidelines handbook for Sri Lankan doctors on cause of death certification. It was distributed to all of the medical officers who undergo training, and also it was tailor-made for the Sri Lankan setting as well. Next slide, please. In addition, we used COD Guide mobile app, a novel way of training, conduct the training as well. Next slide. So based on the MCCD COD pilot results, the evidence-based decision was made to expand the MCCD training. So more MCCD master trainers were trained, and island-wide implementation of the MCCD program through district-level approach was carried out. And training of health administrators and consulted community physicians as district focal point master trainers was also carried out. And in addition, we assigned continuous professional development CPD points for the trainees as an encouragement. Next slide, please. Not stopping by that, next we address the quality improvement of the data flow. As you all know, Sri Lanka has a paper-based CRVS system. So we the amendment of these paper-based formats, that declaration forms according to WHO standard format was carried. Next. So initially we amended the B33 format, which is filled by the doctors at healthcare institutions. Prior to the MCCD training, we implemented the format all the hospitals all over the country, and then we conducted training to streamline the cause of death data flow. Next slide, please. Then we turn into to amend the V18 format, which is filled by the coroners in the medical legal death investigation pathway. And with the introduction of the V18 format, we also conducted training of the coroners on completing V18 format all over the country. And then next slide, please. Then we concentrated on V12 format, which is filled by the general practice for home deaths in order to improve the home deaths, and it has been recently approved and on the implementation process. Next slide, please. Then we are on the process of drafting the 2024 amendment, which is filled by the village health one for home deaths, and it's in the finalized stages right now. Next slide, please. Then we had to address an important aspect of the CRVS system, which is the medical legal death investigation system, which provides gold standard cause of death data. And to address the issues, we had to improve data flow and SOP development, and also conducted gender-based violence workshops to address gender-based violence issues. Next slide, please. So in order to improve the data flow, we developed autopsy notification form, form 1328, to postmortems, following the postmortems, to transfer the data correctly, accurately to the coroners for the data flow. Next slide, please. Then we developed an SOP on safe and dignified management of unidentified dead bodies, which is now finalized and disseminated. And also we conduct workshops for the field level supervising public health staff across the country on gender-based violence, which are helpful to identify and address the GBV issues among the general public. Next slide. Next slide, please. And also we with the capacity building for the ICD coding coders, who are an important stakeholders of the data flow, and we trained all the ICD coders in vital statistics unit. And also in addition, with the introduction of ICD coding within the digital system, what I'm going to explain later on, and currently we are working on that. And capacity building on automated mortality coding on platforms such as Doris and Iris, and also ICD 10 to 11 transition road planners. Next slide, please. So then I will move on to the monitoring and evaluation system of mortality statistics in Sri Lanka. Next slide. So this system is a digitalized system where the data entry occurs at the divisional level, and the quality assurance occurs at the district level, with ICD coding part at the BSU, and central data visualization by the central dashboards in the Regional Department, Ministry of Health, and Department of Census and Statistics. Next slide, please. So before implementing the system, we took a bold step to train all the data entry operators and educated them about the system all over the country. Next slide, please. And since from 2022 February, we conducted the training and implemented the system, and it was launched in March 2023, and we are continuously working to improve the outcome of the system. Next slide, please. So expected impact and benefits. We are working on improving timeliness, quality assurance, and enhancing quality through data-driven interventions, data to policy, and also automatic code. Next slide. So the challenges we met with the M&E system is the monitoring of the progress and institutionalization of training and capacity building programs and data sharing and interoperability, and the maintenance of the system is also an issue, and parallel implementation to digital transformation. So these were the activities we conducted throughout the brief summary, and it is most of the activities led by Ministry of Health under the CRVS improvement program with technical and financial assistance with vital strategies, CRVS improvement program. Next slide, please. So we are looking forward for digital transformation. That means we need more persistence and more collaboration. I think our development partners will continue on explaining that. Thank you. Thank you very much and for your attention. Thank you.
Thank you very much for your in-depth presentation. That's great. We're now going to lastly hear from our colleagues in our WHO and UNDP offices of how the partnerships came together. And I'm wondering whether they're online. Hopefully we're going to hear a bit more about the partners. Over to you.
So,
thank you. Thanks.
Hi. So Ahmed from UNDP here. I will be presenting the project on behalf of UNDP and WHO. Can I get screen sharing access if possible?
Ahmed, you should be able to share now.
Okay, 1 minute. Trying to. Okay. I hope you all can see my screen.
We can see him.
We can.
Okay, right. All right. Thank you. Thanks for the opportunity and interesting to hear from our partners and colleagues on the other projects and initiatives that have been happening. So I will be presenting the one registry project that is being done by UNDP and WHO, jointly funded by the SDG Fund in Sri Lanka and also in partnership with the government. So the project name is Transforming Local Administrative Data Collection Systems for SDG Acceleration in Sri Lanka. So this was a project that was conceptualized about a year back in early 2024, and then through discussions and consultations, it was conceptualized, and then there was a funding call that went through, and we received the funding. So this is mostly for digital transformation of the CRVS system within the RGD, Registrar General's Department, and certain related activities. So I will just take you all through some of the slides. I think some of the things that have already been covered by some of the other colleagues. So I will skip some slides, but we'll give you a short explanation of what this is. So I think this is already covered. Sri Lanka CRVS system, primarily paper-based, high coverage for birth, death registration, decentralized registration officers. There is currently a digital e-population registry data entry is happening at the district secretariat level. There is birth and death data that is being currently entered. There is significant challenges with this current system as it is in terms of how it operates, especially in terms of connecting to a connected government, where the current government has a digital blueprint where they are looking at digital IDs and foundational registries, connecting everything. So for that, there is interoperability and certain issues like that, which are part of the current system. So the One Registry project aims to support the RGD and the government in terms of fixing some of these issues and upgrading some of the systems that are there. The journey so far, bilaterals with RGD from Ministry of Technology, Ministry of Health, ICTA, submission of an EOI, the first UN government meeting happened and all that. Then we had design sessions that happened inside the within Citra Lab, which is is a social innovation lab within UNDP as part of the government also. Here we had several stakeholders. We had 19 different agencies, UN, government, public, private partners who came together to design. I think some of the colleagues on this call also might have joined these sessions. We came together to design this project in terms of what has to be done, how it has to be done, and what needs and all that. So we did all that, and then we had the first steering committee meeting in early this year in January, where it was co-chaired by the president coordinator of the UN as well as secretary to the Ministry of Public Administration. And we also had secretary to the Ministry of Health as well as secretary to the Ministry of Digital Economy also participating as members of the steering committees, in addition to RGB and all the other public organizations that are part of this project. Then we officially launched this project in early February with the participation of the Prime Minister, who launched the project, and then we started working. So like I said, this project was designed with all these institutions engaged. We had RGD, who is the business owner of CRVS in Sri Lanka, and then Ministry of Public Administration, Health, DCS, Ministry of Technology, ICTA, etc., and all the relevant agencies that we understood as should be part of this, who came together to design this project because of the national importance of such a digitized system. Because if you look at it, I think other colleagues spoke about how data is important in terms of making decisions, and there was some discussion that happened with regards to how timely decision making is difficult because there's a delay in getting that data and all that. So what we are trying to achieve from this project is to sort some of those issues where we have systems connected and data flows are automated, so that everything, so from the time someone is born, the data comes into the system, and then from the system it goes into the digital ID and then the vital statistics and any other required so places where it has to go to. So it's part of the national government's national digital vision, where they want to. It's the DPI approach that they're taking. The government is taking. So where everything is connected, and it's CRVS is considered as one of the key DPIs in the project, in the plan. Project elements. So as part of this project, in addition to digitally transforming the CRVS system within the RGD, we are also looking at frameworks, legal frameworks. If anything has to be upgraded, we will also support in terms of doing some of those things. A comprehensive advocacy campaign that will go in terms of CRVS and related components. Then also the digital interoperability platform, being able to connect the CRVS platform to other systems and sources that we require, as well as building trust, transparency, and accountability by strengthening the institution as RGD as an institution also. Beyond that, I think this is beyond the scope of the project, I can tell you. So it's connecting to other government services, infrastructure, systems, and all that. So that's part of that. We also, like, I think my colleagues from Vital Strategies mentioned about capacity building and all that. So we are also working with RGD on identifying what other capacity building that has to happen in terms of hardware, software, as well as trainings that require, which again connects to everything, the advocacy, the BPR, the systems mapping, and everything. So intended transformation, effective CRVS adaptation. I think everyone agrees that we need a robust, inclusive digital system in terms of CRVS, which is user-friendly design, simplicity, and all that. Government initiative for accessible service design, a dedicated government initiative, then data-driven inclusion, right? So data is readily available, and live at all times. It's the live updated data and not data from a backlog or sometime in the past, so that timely decisions can be taken in terms of that. Expected program results, fully digitized, streamlined civil registration processes tested in select divisions, covering half registration times, functioning interoperable CRVS database and systems, and then Registrar General being upskilled in terms of digital and being able to provide services in a digital manner. So that's basically the One Registry program. Again, this is a program that was jointly developed by UNDP, WHO, together with the SDG Fund and international partners who are bringing in the funds and partnering with the government of Sri Lanka. We have the Ministry of Digital, Ministry of Public Admin, as well as the Prime Minister Office, who have signed up for this project, committing for this project. So this is what we have started in terms of UNDP, and we are also working, collaborating with Vital Strategies in terms of how we can work together, and Health Ministry and other organizations also. Thank you.
Great, thanks. So thank you very much, Ahmed, not only for representing UNDP and the partners, but also our own WHO country office today. So thanks for joining. We've heard a lot from the different perspectives, and basically the need for partnership. No one entity can do it itself. Strong leadership, not only from the Ministry of Health, but multiple ministries. The intersectoral elements to CRVS, and the need for stronger digital connections with the CRVS world. What I'd like to suggest just now is, I recognize it's coming up to the hour. We wanted to give plenty of time for you to listen to our presenters. There are lots of questions in the chat. I'm going to read out the questions and then turn to each of the presenters to possibly answer what they feel able to answer in turn. And that might take us about 5 to 10 minutes if people are willing to stay on a bit longer. So I'm just going to read out the questions so our presenters are clear what we're hopefully going to answer here. So first of all is, can you explain how Sri Lanka plans to improve the reporting of the cause of death by village headman? You mentioned timeliness is a major issue. What is the time lag from the completion of a death certificate to its inclusion in the release of official statistics? And what is the way forward from the aspect of the Ministry of Health? And how strong leadership has helped to achieve the changes in the system? How were you able to address death occurring outside the health facilities, which constitute more than 50% of the deaths in Sri Lanka? What is your extension plan for community-based death, especially among the Muslim population? Going forward, will the reporting be continued with paper forms? And sorry, just bear with me. What is the linkage between the MCCD that you mentioned and the DHIS2 platforms that collect data on death and probable cause of death? How is that data interoperability between Sri Lanka Health Ministry and the Population and Statistics departments? And then lastly, any digital public goods chosen for CRVS that you want to highlight? So there's a lot of questions there, but I think that reflects the richness and the depth of your presentations. So I wonder, first of all, I know Romain, I'm going to just go in order. Romain, do you have any last thoughts before we leave the webinar, or answers to some of those questions I read out? So starting with Romain, do you have any comments or answers to those questions? Thanks.
I think I'll leave it to our in-country colleague to answer those questions. They might have much more relevant answer than me. Thank you.
Indeed, thanks. That's what I thought, Romain. Okay, so then next, Dr. Samatunga from the Ministry of Health. Do you want to go and see what, do you have any answer to those questions? Thank you, Dr. Samatunga.
Yes. Now, if I go through the questions one by one, the Sri Lanka's plan to improve reporting of the cause of death. Yeah, actually, in the chain used by for different people depending on the place of occurrence of the death. So medical officers, when we have improved, coroners one we have improved, general practitioners one we have improved. Now only format we need to improve is village headman's one, because one at a time. So one by one we have been improving. And next is the format used by the village headman. In fact, we have really modified the version, and we need only to finalize now with all our stakeholders with one open discussion. There's a procedure when you want to modify a format in Sri Lanka. So we have followed all the procedures, and then we are going to improve in accordance with the WHO recommendations for cause of death in 3 lines, as we did for other 3 parties. So within about 2 to 3 months, we can really finalize and hand over the format to be gazetted, as we did earlier for other 3 formats, to public administration ministry. So we are doing everything with the help of others and handing over to the relevant ministry to publish in the Gazette. So we are happy to mention that. Then next question was timeliness. Oh my God. Yeah, that's a major gap. Now, recently, the Census and Statistics Unit has published 2020 data. So at least by now we want 2023 at least. It's good by June to have the previous year, but at least 2023 data. So I can say that the gap is 3 years, definitely. Yeah. So they are expediting the process now. We hope that soon they will really provide 2021. Then it's time to have the 2024. So 3-year gap has to be done. Then other 2 question, way forward from the aspect. The way forward is to complete the other format, village headman, and to bridge the gap. Actually, a strong leadership is needed to help. So with that only we were able to do all quality improvement of the formats, capacity building of the different stakeholders, declaring deaths, and also our medical legal investigation teams ability and their format. Also earlier, actually our forensic pathologists, they did not have a uniform form after performing a autopsy. Various hospitals had various different forms, but we have now one format, one form to fill, when standardized form implementing by all the forensic pathologists. And most importantly, we were able to do legal review of CRVS, as Dr. Maya mentioned. So for that, we are really happy. And most of the recommendations under each chapter of the legal review, we have now implemented, and very little to go to fulfill other recommendations, like small amendments to the law, because that's how in the estate sector the mechanism was different. But anyway, we have the implicit policy, and one system is being implemented. The last question, what is your how were you able to address death occurring outside the health facility, which constitute more than 50%? No, it's about 45% to 50%, not more than 50. 50 exactly is happening in the hospitals. What is your extension plan for community-based, especially among Muslim? Whether Muslim, Tamil, Burgher, or Sinhala, we one system we implement the standard format, and the situation under which you do a inquest is same, very much established the reasons, and we really respect different religions and their beliefs. What we do is to implement standard procedure as much as possible soon. I mean, as soon as possible, and release the dead bodies, and in respectful manner. Actually, in that aspect, I think we can say it's satisfactory arrangement is there. The good coverage of forensic pathologists. When there's a vacancy, the next available forensic pathologist is covering up the vacant areas, and also Grama Niladaris are there. And we have very well trained by health sector inquiry into sudden death. So, so one system is being implemented, and as soon as possible, we accomplish all the steps involved by all the Grama Niladaris and inquirer into sudden death. That's all I think the questions.
Great. It's fantastic answers and really added depth to the discussion. Thank you for your in-depth thoughts and solutions as well. Thanks for that. I wonder whether I could turn to Dr. Maya now, and wonder whether you have any thoughts on the questions asked or anything else you want to add. Thank you, Dr. Maya.
Thank you. I think most of all the questions were answered by Dr. Somatunga. And there's one more question that I think with the digital transformation, I think Mr. Ahmed Nishant has answered that question going forward with the paper-based forms. I think he has given the answer. And also, Dr. Usman has asked whether there's a linkage between MCCV and DHIS2. Anyway, we are not using DHIS2 in Sri Lanka for the moment. So, with the upcoming digitalized system, we will be accordingly. I think that's all. I think with the upcoming digital transformation and digital public infrastructure system, I think most of the loopholes will be addressed. Thank you.
Great, thank you both. And lastly, but by no means least, I wonder whether Ahmed, you had any thoughts on the questions or want to emphasize the power of partnership on behalf of UNDP. Thanks, Ahmed. Any other?
Thanks, Rick. I think in the interest of time, I answered some of the questions on the chat itself, but I think CRVS is a very important system that is required for any country, and having a digital CRVS in terms of the current era is important, and all the partners working together, I think, again, is much more important. We are happy to have Health Ministry, Vital Strategy support us, and the Registrar General Department, everyone coming together, WHO and UNDP working together on this and trying to implement this digital system. So everyone coming together is important. I think as SDG number 17 also says, partnerships for the future, right? So partnerships in terms of getting things done and going forward. So looking forward to working with everyone also in the upcoming years. Thank you.
Great, thanks, Ahmed. And thanks to all our presenters today for sharing the rich experiences from Sri Lanka and beyond. And thank you again for the leadership that the Ministry of Health in Sri Lanka has shown in this initiative. I think we've all learnt a huge amount on the CRVS agenda in Sri Lanka, especially the need for digitalization, the need for partnerships, strong leadership in the Ministry of Health, and the fact that CRVS is a multi-sectoral and multi-ministry issue as well. So a huge thanks for everyone for joining today. I know we went over time by about 10 minutes. We started a bit late and wanted to thank you and encourage you to join other HDC webinars that might be of interest to you. And a huge thanks to my colleague Pandula, based in Colombo, for pulling this together with Ministry of Health colleagues. So thanks everyone for joining, and have a good rest of your day. Thank you.
Thanks, Craig. Thanks, everyone. Bye.
Thank you.
Bye.
Anthony.
Thank you.